All right. Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's subject is on the QTC and a tool in your toolbox to ensure that your patients truly have a prolonged QT, because humans are still better than machines, at least for now. And our guest today is the outstanding Dr. Margot Funk. Dr. Funk is the director of cardiovascular psychiatry with the Division of Psychiatry at Brigham and Women's, where her clinical practice is focused on the psychiatric care of patients with complex cardiovascular illness. Our format for today is going to be a presentation, a little bit of interaction sprinkled in, and then we hope to have a few minutes at the end for some questions from the audience. So Margot, it is an absolute pleasure having you here with us. Welcome, and I transfer the floor to you.
Awesome. Thank you so much for the invitation. I love to talk about this topic. And so what we're going to focus on today is, QTC prolongation, when we should versus when we shouldn't worry about it. And we're going to frame that from a palliative care standpoint. We will be doing a little bit of audience polling today, so please take a moment to join the poll. You can do that either by going to the URL pollev.com/MargotFunk977. You can send a text MargotFunk977 to the number 22333, or you can use the QR code on your screen and jump into it that way. All right, so let's jump right in. So I think it's nice to frame the discussion with a case that may be similar to what you experience in the palliative care setting. I myself am a CL psychiatrist, so I do most of my work in the hospital, except when I'm seeing outpatients in a cardiovascular psychiatry setting. So this is Ms. S, and she's a 72-year-old woman, has a history of remote endocarditis from actually a dental procedure in her 20s that resulted in kind of a lifelong of multiple mitral valve replacements over the last 40 years. That's been complicated by AFib. She has an ICD in place for primary prevention, and she's continuously paced at 75 beats per minute. So she recently suffered a fall after she tripped on a loose hose while gardening in her yard and resulted in a sacral fracture. Her radiographs revealed incidental findings of multiple osteolytic lesions, and then further workup revealed lung adenocarcinoma with mets to liver and brain. And, she has been, really going through medical complications of this initial endocarditis for her entire life, decades now. And she doesn't want to pursue any further treatment for the cancer, really wants to end life peacefully without pain. Her meds currently include warfarin, lisinopril, furosemide, and potassium. So you are thinking in this setting, well, maybe we'd like to use methadone to manage her pain. But then when you pull up her EKG, this is what you see. So looking in, first you'll see that, you've got the EKG, you have the machine read at the top, and the machine read tells you that her heart rate is 75 beats per minute, that she's being paced. And you can identify that pacing yourself by seeing these little ventricular pacing spikes that immediately precede the QRS complex. And you can also see that the QRS complex itself is wide. The machine is telling you that it's 186 milliseconds. And if you recall, the normal range for QRS complex is 80 to 100. So pretty wide. You also see here that the machine read for the QT interval is 492 milliseconds, and the QTC is 549. So keeping all of this in mind, on your initial review of her EKG, do you think it would be safe to start methadone? So take a moment just to think, okay, based on what I know, do I think it's safe to do this? So now I want you to jump onto the poll if you haven't already and tell us what you think. You can put A, B, so A is yes, B is no, C, not sure. So let some answers come in. Right now we're like 50-50, yes or no. No one is not sure. Okay, so that's okay. So now we're a bit more of the nose on that. Okay. So we've got a mix. So I want to hear from either group. So why or why not? Why do you think it's safe to use methadone? Why not safe to use methadone in this patient? Love to see your thoughts. You can just type those directly in. Okay, so long QTC per the machine read. Wide West for long QTC. Wide QRS. So maybe wide QRS is a reason why it's okay, maybe. What other thoughts? Okay, so a lot of folks are saying, okay, so prolonged QTC, yeah, it's over 500. We see that, and we instinctively get worried. Does it matter with prognosis? Also, I think a really important point, which we're not going to discuss much today, but I think that's a whole nother layer of this conversation. So let's kind of take a step back and think about, okay, well, why we're saying QTC is prolonged. Why do we pay attention to QTC in the first place? So we know that QTC prolongation is the most widely accepted marker of risk for torsade de pointe, which is a malignant ventricular tachycardia, polymorphic in nature. The name means twisting of the points, which actually reflects what you see on the ECG, which you can see here, where you have this twisting of the waveform between high and low amplitudes around the isoelectric baseline. And torsades can present in a number of ways, from being lightheaded to syncopizing. Some people may have seizure-like activity, and for many people, it may result in sudden cardiac death. Now, we know that most cases of torsades will occur in one of two settings, either congenital long QT syndrome or acquired long QT syndrome. Congenital is genetic in nature. It has a characteristic long QTC at baseline. And acquired long QT really occurs in the setting of acquired risk factors incurred by the patient, often things that we are doing to them, and including many of the medications that we may prescribe. And so methadone is one of those. So these are the risk factors for torsades, which I like to break up into thinking about, what we can control and what we can't. So things we can't control: female sex, advanced age, their metabolizer status. Maybe they aren't as good at metabolizing one of these high-risk medications. Certainly, if they have a genetic history, if they themselves have had QTC prolongation, or they've had torsades ever in the past, or just if you know that they have any sort of structural or functional heart disease, and also a family history of sudden cardiac death. Those are the things we can't really change. Things we can change are the medications that we prescribe. And we know that when we prescribe more than one medication that's QT prolonging, that also can have a cumulative effect on risk for torsades. We need to think about drug-drug interactions, certainly in cases of overdose, or if you're giving too much, that can increase risk. Being just severely acutely ill, thinking about multiple organ systems not doing well or shutting down. Bradycardia is a really big one, and that's probably a take home to remember about QTC is torsades likely won't happen when you're tachycardic, but when you're bradycardic, your risk really goes up. Starvation, hepatic impairment, renal impairment, and then, of course, hypokalemia, hypomagnesemia, or hypocalcemia. So these are the things that we can change. So thinking about the medication piece and thinking about our case with Ms. S, and then focusing in on methadone. So methadone is one of these medications that I always highlight to my residents, like, you must beware of methadone. This is a high risk medication. Not only is it known to prolong the QTC, it's in a very high risk category for actual torsades, with a lot of case reports and data demonstrating that torsades can happen with methadone. Another interesting fact about methadone is that the parenteral formulation has an even higher risk than the PO formulation due to chlorobutanol, which is a preservative that's in that preparation, and it's also QT prolonging. Data is equivocal regarding dose-dependent effects on QTC prolongation, but we do know that torsades does occur even at low doses. So to really, highlight for us then too that methadone is something to worry about. In 2006, the FDA issued a black box warning on methadone, stating that cases of QT interval prolongation and serious arrhythmia have been observed. And so we're aware of it. Okay, so we got that in the background of our mind. So now I want us to think, a little bit more about the electrophysiology and how that ties into what you're seeing on the EKG when you're thinking about this case with Ms. X or Ms. S. So I want you to start out with, so you'll see kind of 3 panels to this figure. We're going to start at the figure on the left. This shows what's happening electrophysiologically in the heart, and then below it demonstrates what's happening on the EKG. So on the left, and thinking back to our cardiac conduction system, we know that the signal goes from our SA node to our AV node. This marks atrial depolarization, which is going to be represented by the P wave. And then in the middle figure, you see this rapid conduction that continues from the AV node into the bundle of His. You have these right and left bundle branches, and then your Purkinje fibers. And this marks ventricular depolarization, which is represented on our EKG by the QRS complex that you can see down here in pink. Repolarization of the atria is happening concurrently. Then if we looked at the figure on the right, we see that ventricular repolarization is marked from the end of our QRS complex, which is called the J point, to the end of our T wave. And most importantly, especially for our conversation today, I want you to make note that though it's the QT interval that has been used as this, electrophysiologic marker of torsades risk, and notably it's a major drug safety benchmark that the FDA uses, the QT interval actually represents both depolarization, which you see in the pink QRS complex, and repolarization, which is shown by that aqua JT interval. And those are actually fairly separate events. And what we know about torsades is that it occurs when there is prolongation of repolarization. So it's really this third heart here that we're worried about. And the QRS complex doesn't really play much of a role here when we're worried about torsades risk. So then we have to think about, okay, well, what if the QRS complex is wide? How does that play into how we determine if there's actually risk for torsades or not? So let's keep diving in. And I want to talk a little bit before we put all the pieces together about QT interval just in clinical practice. The first thing to know, I think, is that we have to account for the fact that it is heart rate dependent, meaning that the absolute QT interval is going to vary depending on the heart rate. So the longer the cycle length or the longer the duration of one beat, as you can see in this graph, the slower the heart rate or the longer the measured QT. And another way to think about it is, so if you look at these 2 little cartoon characters of the same person, if one figure is at rest with a heart rate of 70 and the other guy is running at 110 beats per minute, there's actually no difference in the repolarization mechanism, but we have to somehow correct that QT interval for heart rate so that the marker of risk is consistent whether someone is at rest or at play or anywhere in between. And this is just another way to look at it, now adding rhythm strips to these little guys. So same person, but we see that when running and has a faster heart rate, that QT interval will inherently be shorter. And thus we need to correct that so that we have a consistent marker. So how do we correct for heart rate? We have multiple QTC correction formulae. The most common one is the Bazet formula, which is the QT interval in milliseconds over the square root of the RR interval in seconds. Bazet is the formula that's been default programmed into most ECG machines, and same in most electronic EKG management systems that you may have like in your EMR, so like Muse. It's also the formula that's been used in most QTC research, and up until a few years ago, it was the formula used by the FDA. That switched in 2017. Unfortunately for Bazet, it's the most inconsistent of all the formulas. It's going to overestimate your QTC at high heart rates and underestimate at low heart rates. So we actually don't like to use Bazet, and it's the one we recommend to stay away from. Unfortunately, that's what the computer is spitting out at us. So the three others that are commonly used are much more consistent across heart rates. There's Friedreichia, Framingham, and Hodges. Friedreichia is the new formula now used by FDA in their QTC analyses. Framingham and Hodges are both linear regression formulas, and these are what are most recommended by the American Heart Association, American College of Cardiology, and the Heart Rhythm Society. I think bottom line is you can use any of these three and you're going to get more accurate results than you will with Bazet. And so hence, I think strong reason to learn how to measure your own QT interval and how to do your own calculation. And luckily we have many tools on the internet or apps that are readily available where you just plug in the numbers and you can pick which formula you want and it'll spit it out at you. So QT interval is considered prolonged in men when greater than about 470, in women 480. But in clinical practice, and really based on a large body of literature demonstrating that torsades really only occurs when QTC is above 500, we become more concerned at that 500 number. We also get concerned if we've made an intervention with a medication and we see a jump upward of 60 milliseconds or more. What's important, though, I think to remember is that there's actually no absolute QTC at which an at-risk medication can't be prescribed. And you really have to prescribe based on an individualized risk-benefit analysis for each patient. And so going back to, that the initial question, well, does it matter because of prognosis? I think that may be part of your risk-benefit analysis. So keep that in mind. Other reasons why I don't love to use the computer-generated QTC is because there can be a lot of variation between machines. Oftentimes, they use kind of an amalgam of representative or median complexes, and typically they use Bazet. So again, recommend that you do your own QT measurement and heart rate correction. And as a reminder of how to do that, remember that the small box on your EKG represents 40 milliseconds, large box equals 200 milliseconds when you're actually counting it out. Okay, so let's go back now to Ms. S and her EKG, and let's try this out and see what we get. So typically when I'm looking for, which place on the EKG to make my measurement, I'm going to look in leads V2, V3, or lead 2. Any lead will actually do. Most importantly is being able to identify where your T wave ends. But typically we start in that area. So I'm going to start here in V3 and zoom in here. And so we're first going to find beginning of our QRS complex. We're going to find the end of our T wave. We're going to count the number of boxes. And so we get a QT of 480 milliseconds. So that's pretty close to what the machine has rendered for us. We're going to plug that into Hodges and we get 506. So this is different than 549. So that's one piece to note. But then going a little bit deeper into this, we remember that Ms. S is being paced and that she has a much wider QRS than normal, which is contributing to that long QT interval. So is there a way that we can correct for that? Here's another way of kind of looking at that piece of the puzzle. So, remember I mentioned the QT interval actually represents both depolarization by the QRS complex and repolarization represented by the JT. And so when we have a widened QRS complex, that could be either due to a bundle branch block or to ventricular pacing, you're going to have longer QRS complex. And the reason why in pacing you have a longer complex is that instead of having this rapid conduction through your His-Purkinje system, you basically start where that electrode is implanted and you have cell-to-cell propagation of that electrical signal. And so it just takes longer for depolarization to occur, hence the long QRS. And that's why we see the long QRS in Ms. S. It's because of that pacing. Okay, so basically what we want to do then is we want to figure out a way to kind of take the wide QRS out of our equation. So this is a flow chart that's a schematic of how you might approach a QTC in a patient with pacing or bundle branch block. And the first thing to ask is your QRS greater than 110? And then you're gonna say yes. So thinking about Ms. S, yes, hers is greater than 110. And then there are two ways that you can correct for this. You can use a method called the Gaussian formula, which basically it takes the QT interval that you measure and you subtract from that half of your QRS and you get a modified QT interval. And then you're going to correct it the same way for heart rate as you would do with any other QT. The other way to do it is with the JT interval. And so instead of measuring the QT, you measure the JT and you correct that again using any of the heart rate corrections except for Bazet. And that's a really easy way to do it. I'm going to show you how we do that with Ms. S. So you can use one of those two methods. A thing to know is that when you're using the JTC, there's going to be a different kind of cutoff point of normal. There's not great data on this, but in general, what we use, this is based on one paper right now, in men, 355 milliseconds as a cutoff, and women, 372 milliseconds as a cutoff. So that's for JT. There is also a completely different formula and approach to doing this called the Rata-Harju formula. This incorporates the QT, the heart rate or the RR interval and your QRS, but this is a very unwieldy formula that most people are not going to use at the bedside. So I tend to stay away from it, but it may be actually the most accurate out of everything. So let's try this with Ms. S. So here's her EKG. We already know she's at 480 milliseconds for her QT. So let's measure our own QRS. So we get 4 boxes, about 160. So let's plug that in. So yes, greater than 110. And let's plug this in now to the Gaussian. So we put in 480 for our QT. We put in 160 for our QRS, and we get a QT modified of 400. And then let's plug it into Hodges, and then we're going to get 426 milliseconds. So that's quite different from our 500. Much, much different. And I would say, 426, that seems pretty safe to me. Let's try it with the JT interval. So here we got that one is safe. So JT interval, count out 8 boxes, 320 milliseconds, or you just subtract the QRS from the QT. Let's plug that in. And then when we correct that with Hodges, we get 346 milliseconds, which is less than the 372 for women. So I also am thinking, okay, this seems pretty reasonable. So you can see that there's this pretty big difference here for Ms. S in terms of our initial reaction, seeing that EKG of like 549, but when we actually account for both the heart rate correction and the pacing, we get something that's very different and more accurate in terms of how we're going to estimate her risk. So now that we've made this correction, you decide to start methadone, and she does very well. She's got significant pain relief. 3 days later, you get an EKG and you find that her JTC is now 400. So how might you approach the case from here? I'd love to see your thoughts. Again, depends upon goals and prognosis. Any other thoughts? What was the pre-JTC? Yeah, so I think we said it was like three, I don't even remember what we said. It was 320 something. So it was under no, maybe it was 340. So way under the 372. Reasonable to rotate opioids. Yeah, you could absolutely do that. Would be concerned about a significant change. Yep. Yeah, so I think all of these things are part of the discussion at this point of what to do with her. I think coming back to the goals of care are probably going to be most important. And you may want to think about, are there other risk factors that we talked about that we could mitigate? Certainly rotating the opioids could help mitigate. There may be other things. But then again, what are the goals of care for Ms. S? So in terms of take-home points, and then we can hopefully have a couple minutes for discussion, I want you to know, so don't rely on the EKG machine, all right? Do your own measurements, do your own correction. Remember that Bazet is bad, just don't use it. All the others are fine. Correct the QT when you have the wide QRS. And I usually use the JTC. I think it's super simple and easy. And this can really make a difference in whether or not you're going to prescribe something, whether it's methadone or something else. Remember that 500 is not an absolute cutoff, and always have to consider that the risks of torsades versus the benefits of a medication in the context of patient goals. So I'm going to stop there and would be happy to answer any questions that anybody has.
All right, thank you, Margot. Let me pull up some of the questions that have popped up in the
Great.
chat. So first one is from Steve, and he was hoping you might offer a recommendation if there's a particular app that you've used for calculations that's pretty user-friendly.
Yeah, I like the MD Calc app. And they actually have many different things on MD Calc, but they will allow you to basically plug in your information and then you can pick which formula you want. And it's sometimes fun to put in the different formulas and just see what is the variation between them. And often what you'll find is that Bazet does separate out from everything else. So I use MD Calc.
And Patrice has got a question I'm going to build on as well. So first, she's kind of mentioning, well, how do you recommend documenting some of this? But also, how do you approach some of these other physicians that may disagree with you, maybe even a cardiologist? And have you done that? Can you give us some pointers?
Yes. So what I document is that I document that there's a wide QRS complex. I document the formula and approach that I've used. And so when I do JTC, I will put in, JTC equals this, which is less than, kind of what we consider cutoff point for normal versus abnormal. And then I describe my decision making based on what I want to do from that information. You're right that cardiologists often don't get this far into the weeds on the EKG. My husband is actually a cardiologist, so we talk about this all the time at dinner, and even some electrophysiologists may not get into this. Now it's interesting. In our program, our residents know this so well now that they have trained the medicine interns, and people are just starting to get it. So it's sometimes that's a good place to start if you want to shift the culture in an institution on this issue, is to start with the trainees. But typically, I think if you just kind of walk through the rationale in a very kind, way, then physicians will say, "Oh, okay, well, I guess that does make sense. I didn't realize that, but yeah, okay." So I do it gently.
All right, we've got one more question, unless something else pops up. So Rachel's asking if there's an app that calculates the risk of torsades, but I think you can even expand on that. Is there even really good literature that even gives us a sense of the risk of torsades? Because I worry that might be lacking.
Yeah. So there are some proposed risk calculation systems, and most of these actually have been developed by pharmacists. So there are a few hospital systems that have them. One is called the Tisdale score. There's actually a book called Torsade de Pointe by James Tisdale, who developed this score. I think the issue is really going back to the fact that many episodes of torsades are going to happen out of hospital, cardiac death that's never known, and it's really hard to study. It is not an endpoint or an outcome that we have great data on. So I think then, that makes it really difficult for us to be able to, say with certainty based on just, assigning numbers to number of risk factors, what is the actual risk? I would say there are some risk factors that I consider more risky than others, and sometimes I use that approach. So for example, bradycardia, that worries me a lot. If you're on hemodialysis, you got really rapid fluid and electrolyte shifts, that worries me quite a bit. Those are probably the big ones, but again, depends on your goals of care.
Sure. All right, we're just about at time. Margot, thank you so much. This was
my pleasure.
It was an absolute pleasure for us as well.
Great.
All right, everybody.
Thanks so much, everybody.
Weekend.